So just before we hit relapse, just to then briefly discuss doublets or triplets in frontline setting. So let's talk a little bit about the Captivate study. The combination of Ibrutinib and Venetoclax, the high responses that we saw. What do you think about that? You know, there's obviously a very, you know, folks are very interested in obviously then taking away all intravenous therapy and doing 2 orals, you know, 2 novel targeted agents together, limited duration of therapy. Is that ready for prime time?
I don't think it's ready for prime time. It's exciting data because we get patients into deep remissions with a non-chemotherapy regimen, and most patients, at least in the frontline setting, become MRD negative in blood and in bone marrow, and that's a gateway to limited duration treatment. But the problem there could be, well, first, it is more toxic, the toxicities add up, and then we don't have any long-term follow-up data. And we know single agent treated patients with Ibrutinib in particular, or with BTK inhibitors, have very good outcome with a single agent, and we just don't know if the outcome is going to be definitely better. Is there maybe a cure fraction? I guess that's what the hope is, but unless we have longer term follow-up, I think I would not recommend that.
I do want to hear this one too.
Oh, yeah, sure.
No, so, and I was just going to add to that.
just you know,
No,
there's very nice data out of MD Anderson and from the Captivate, so.
Absolutely, and I think that the combination of Ibrutinib and Venetoclax is extraordinarily powerful. The tolerability does become an issue, and that certainly is something due to not just drug-drug interactions, but overlapping toxicities. So one of the important questions that I like is whether or not we can find a better combination. So acalabrutinib venetoclax, umbralisib venetoclax, duvelisib venetoclax, these are all different combinations that may actually yield very, excellent results with far better tolerability. I very much, enjoy not having to put IVs into my patients, and so I think the total lack of intravenous component is an important part of that therapy. One piece of data that I just want to highlight are, the data from OSU, looking at their, this is Jennifer Wowach's data, looking at reasons for treatment discontinuation for patients on Ibrutinib. And their estimate was that if you were not 17p deleted, did not have a complex karyotype, and were age over 65, you had a 98.2% chance of being free from progression on single agent Ibrutinib. So for those people, we really could never do better. And so that a lot of what we're talking about are for the other patients, the patients who may really represent about 20% of CLL overall. And so when we do start looking at these data, it's going to be important to identify that, whole population of CLL patients might not yield the data because it's not going to be enriched for the ones who may actually benefit. So I could see one day us being able to say, well, you only need single agent Ibrutinib, but you need Ibrutinib venetoclax or some BCR, BCL2 combination.
Yeah, so that begs the question that obviously in frontline setting, given that we need much more mature data, does everybody with CLL need a doublet or a triplet?
I think ultimately there might be a combination strategy that we'll all use, but at this point I still don't feel that it adds substantially to all the other drugs that we have, and I think we just need to give it more time. And then the other argument, again, that happens is if I use all 3 of my most active agents up front, how do I salvage those patients upon relapse? Can I retreat them? Can I switch agents? And I think those are, again, questions that still need to be addressed. We have preliminary data on those yet, but we don't have systematic trials which are addressing this question. Okay, time-limited therapy with 3 drugs, stop, and then retreat upon relapse, and what's the long-term outcome? So I think all of those are interesting questions. Does that change my practice right now outside of a clinical trial? And the answer is no.
I think I want to add that for sure the data and the long-term data with Ibrutinib is very strong, and we have many, many patients doing very, very well. But I think we need to go back to the time-limited therapy versus long-term therapy, and I think it's something of the widely interest in our patients. So I think I was also caught by the attention of one of the abstract presented, the addition of venetoclax just with a goal to discontinue ibrutinib, something that in the future, I mean, obviously is a research question, but I think we're going to really see more and more. And also really going back to the fact that, you know, the mechanism of action of BTK inhibitor and BCL2 inhibitor, they are quite complementary. And I think, in my opinion, also really address two different compartments, more like a lymph node compartment versus bone marrow compartment. So at some point, and I think we're going to see this kind of trials more and more, adding a second agent, maybe for a certain period of time, so patients can really ultimately discontinue therapy. And once again, I think classically we always really try to, it is true that it's always a concern when you really put everything in the beginning, but at the end of the day, historically in medicine, we try to incorporate the best therapies, even alone or in combination, the sooner, and we have better and better data. It's true that it's hard to really beat this 98%, but I think we are going to the fact that, well, is our chronic toxicities may impact also the quality of life in our patient. So we need to really start to thinking about these trials in the future.
So there might be some subgroups that might benefit from a doublet or a triplet up front.
Absolutely.
But the data is still immature.
Absolutely. But again, I think need of time-limited therapy and even finance and toxicity is some things that is going to really pan out in the future, in my opinion.